Welcome to a special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy Show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl and other guests on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. This next theme is on decriminalizing mental illness. Today, Dr. Cutler will be interviewing Dr. Stahl and Dr. Katherine Warburton on the history of criminalization of people with serious mental illness and the subsequent efforts to decriminalize mental illness with diversion programs and improved community awareness. Let's listen in to part 1 of our theme on decriminalizing mental illness.
Welcome, everyone, to another edition of the PsychopharmaStahlogy Show, a series of NEI podcasts featuring the one and only Dr. Stephen Stahl. And we've been doing a series on various topics, and today I'm very excited about our topic, which is decriminalizing mental illness, with Dr. Katherine Warburton. And we're thrilled to have you here, Kate. How are you doing?
I'm well, thank you. How are you?
I'm really doing well. This is a topic that I think is near and dear to all of our hearts, all of us who work in the field. We're all aware of the fact that the largest providers of mental health services, sadly, these days are the criminal justice system. How did we get to this place?
Well, okay, that'll take the entire hour. That's something that we've been asking a lot. And in fact, a couple of years ago, we had a forensic fellow from Australia come over and want to do some work for us. And Dr. Stahl and I actually presented him with a challenge, which was to read the entire history of the treatment of people with serious mental illnesses across time and geography and let us know, what went wrong. And it was a very interesting project to work on together. We went and interviewed a historian on the history of psychiatry and read everything that was available to us. And what we discovered is there has never really been a time or a place where human society has taken adequate, sustained care of people with serious mental illnesses. It's been more of a cycle of locking people up or institutionalizing them, neglecting them in institutions, or letting them out into the communities, neglecting them in the communities. So it's just been a cycle of incarceration or institutionalization and neglect throughout time and history. And so I would say the most recent set of circumstances that have led to this point of the cycle that we're on came in the wake of deinstitutionalization, which was an incredibly well-intentioned, noble effort by society to deinstitutionalize, de-incarcerate folks. But the way that the community resources and the community funding flowed and kind of the lack of accountability on those dollars and those programs, specifically for people with psychotic disorders, ended up with this sustained period of neglect that we've had over the last few decades. And for people who have, they lose their capacity, they lose insight, they become delusional, most become unsheltered, and then they end up with repeated criminal justice contacts. And then they get locked into the cycle of criminalization. And we have a lot of research and data in our own system, as well as having reviewed the literature that supports that hypothesis.
It certainly makes sense. And maybe I could just back up for a second here. The deinstitutionalization, of course, as you said, was very well-meaning and came about largely based on the advent of the first-generation antipsychotics, chlorpromazine and others in the 1950s. And I guess in the 1960s, then people thought, hey, we were able to now treat these folks. And there was this idealistic sense that we could treat in the community. Is that a fair way to say it?
I think so. I think the advent of effective antipsychotic medication was a large factor in deinstitutionalization. I think the other large factor was that the so-called asylums that had been built in the middle of the 1800s to late 1800s to care for people who'd been neglected in the community, these asylums became grossly overcrowded, and the conditions became quite inhumane. And so by the middle of the last century, there was a series of investigations, exposés into the conditions in what were then asylums and are now state hospitals. And I think that also precipitated the deinstitutionalization movement.
So it was a couple of different forces working together. I actually worked in the United States Senate as a mental health advisor to a senator and did a little work on this. And my understanding also is in the 1960s, of course, with the Kennedy administration, was the establishment of the community mental health centers. And the Community Mental Health Center Act, I believe, was passed in order to try, and that might have been under the Carters, to try to fund this wave of deinstitutionalization. And sadly, in the 1980s, I think the funding was inadequate and might have even been cut. And this led to a big rise in homelessness, actually, in the 80s and 90s. Is that fair to say?
Yeah, I think that's fair to say. I think there's a great chapter in a book by Fuller Torrey, who's a thought leader in this space. Yeah. And he really kind of describes the Community Mental Health Act funding and how that was administered in a way that it was difficult to know where the money was going. And it was difficult. There were no outcomes, for example, being measured. And that was one of the structural sort of policy problems in the 1960s with fractured funding sources that we still have today, where there's no one entity responsible for this group of individuals, specifically people living with schizophrenia spectrum disorders, from a financial perspective.
Yeah, and it also sounds to me like a chronic problem that people kind of get overexcited or overestimate the ability of medications to help and not really understanding or anticipating all of the other services and treatments that are needed.
And housing, especially in California, housing's a big one. Although I had this conversation with Dr. Stahl quite a bit because he devoted his career, not to speak for you since you're actually on this conversation, but he devoted his career to the development of effective psychopharmacological therapies for psychosis. And what we're finding in our research and our work is they're not getting to the patients. Schizophrenia, when detected early, is treatable and people can have a good quality of life. But for example, half the people coming into our system under some sort of forensic commitments or criminal charges have been filed in these cases. Half of them haven't had any mental health services in the 6 months prior to their arrest.
Wow, it's criminal. I mean, to use a double entendre. Steve, what do you think about this?
Well, it's a sad realization that we're starving in the midst of plenty. Our medicines go far away distant from cure. They're not cures, but they can make the difference between stable housing and a decent life and finding meaning in your life and not, and living on the streets and being exploited and then actually being swept into the criminal justice system. So I think the reality is that we're learning that early treatment can prevent progress, and that the best way to keep people from becoming psychotic again is to catch it in early episodes, if not first episode, and treat it, unremittingly. It's a lifetime illness. Keeps people from getting treatment resistant and having, continued symptoms. So we have all this possibility, and people are not getting treated.
Yeah, and it's analogous to cancer or heart disease, which the earlier you treat, the better the outcomes are. And society would never tolerate what we're doing with mental illness, with these other illnesses.
Absolutely.
There's something about serious mental illnesses, and as I mentioned, throughout time, society just hasn't felt a responsibility to care for this group.
That's very surprising to me, Kate. I suppose the myth I was living under was there was a time when people with mental illness were sort of exalted or celebrated as clairvoyants or oracles or something. Maybe that's just not true.
I think there's some of that in distant history. But when you look to the 1700s, 1800s, people with serious mental illnesses were chained to walls and kept in cages and, just horrific conditions. And that's why they built asylums, which are now state hospitals, was as the answer to those conditions. And if you read mental health leaders in the middle of the 1800s writing about the asylums, they really thought they'd figured it out. They thought this was the answer, and they were congratulating themselves on finally becoming a humane society across the world. Scotland, Germany, the United States, everybody thought the asylums were the answer. And then the asylums became, 100 years later, they were called snake pit. And, it's a cycle.
Was there a time early on when the asylums were considered, when they actually were a good form of care?
Absolutely. Absolutely. And and Dorothea Dix in this country was the leader of this movement. And they were these gorgeous, they were called Kirkbride buildings, these gorgeous, beautiful, Gothic capsules where the doctors would live there, the patients would live there. They would take in nature and fresh air and garden. I have a report from my alma mater, Napa State Hospital, from 1898, and it was a data report to, the central agency at that time, reporting on all the produce that they'd grown.
Yes.
And that, and now we're collecting data on, number of previous arrests and, all kinds of terrible outcomes. But back then, their most important outcomes were, how many carrots they grew that year. So that was a golden age. And it was a wonderful idea, but it was not sustained. And society stopped funding those institutions. They went from having, 5,000 individuals in state hospitals in the United States to 500,000 by the middle of the 1900s and, terrible conditions. And so then they had another great idea. Let's deinstitutionalize folks. But then a lack of sense of accountability or responsibility to this group, again, has led to the situation we're in now, where people are now being reinstitutionalized, but this time under a forensic commitment or reinstitutionalized in a jail or prison. And it has reached a crisis point nationally.
What do you mean? Tell me more about that.
The mechanism by which people are now being reinstitutionalized is through something called an incompetent to stand trial commitment. So if an individual is arrested and they are so psychotic that they don't understand the charges against them, or they can't cooperate with their attorney, there's an evaluative process that's done, and constitutionally they can't stand trial because it's unfair because they don't understand the proceedings. And so they get sent to a state hospital to be what is called restored to competency. And that, in my opinion, is just another term for stabilizing that individual on medication so that they're no longer experiencing psychotic symptoms. And then they get shunted right back into the criminal justice system where they, stand trial, and then they either go to prison, worse off, than they started, or they're just released right back out into the same circumstances that precipitated that arrest. And that those circumstances are most often homelessness and lack of treatment. And so this IST crisis has been growing over time, really started in earnest around 2014. And so now states have these waiting lists of individuals. You can think of the IST commitment really as a proxy for people with psychotic disorders being arrested, right? And so the states have seen massive increases in the number of people being found incompetent to stand trial, and we simply can't accommodate them in these very expensive state hospitals. So they're sitting in jail. And we did a survey of states in 2017, and we had 50 out of 51 jurisdictions, including the District of Columbia, respond. And I think 81% of jurisdictions reported an increase in these competency referrals. And so then what happens is you get into a federal litigation situation to try to get people into the hospital faster. So you find yourself in this ironic position of civil liberties groups suing states to institutionalize people in state hospitals. Like this is what it is. It's tragic and horrifying. It's also laughable that this is how our society has evolved in the year 2022. This is what we're doing with people who have brain diseases.
Exactly. And states like Florida, where I am, and I believe California, have various programs now, diversion type programs, correct?
Yes.
And how do they work, and how can they potentially help?
Well, in Florida, you have the best diversion, I think, in the country under the leadership of a visionary judge named Judge Steve Leifman. So diversion is a mechanism. Diversion is a word that describes any effort to divert, to move someone with a serious mental illness away from the criminal justice system and towards treatment. And
Right.
so it can happen at any point where that individual has the potential to have criminal justice involvement. And you really just have to sort of craft individual programs to address at what point the person is having that contact. And then you have to have the actual treatment program to divert them into.
So again, it comes down to funding, it sounds like.
It's funding, and we have this phrase that we use. It's about institutionalizing compassion. Instead of institutionalizing people as a society, we have to start institutionalizing compassion and feel like this is a priority to create places for people with serious mental illnesses to go that isn't a street or an institution of some kind.
Yeah, I believe actually the diversion program in Florida actually started in the late 90s under Jeb Bush when he was governor. He was extremely devoted to mental health. And it, like you said, it just takes certain champions, certain individuals, ideally politicians and in the legal system, I guess, to do this.
You know, the ones that I see that really work well have a charismatic judge leading. We have a couple of judges here in California as well that just inspire people to try to get these folks into treatment.
Well, when it comes right down to it, it makes sense, doesn't it? I mean, it just makes common sense.
Oh, and it makes fiscal sense. That's the other part of this. We did a project where we just looked at the economics of doing the right thing, and you save an incredible amount of money. State hospital beds are the most expensive place to put someone with a serious mental illness. And the one thing I want to say about that IST commitment is that it's not doing anything to interrupt the trajectory of that person's illness. We are simply medicating them long enough for them to stand trial, and then they go right back out into the same circumstances that precipitated the arrest.
Yeah, I mean, it's not even a Band-Aid, really.
No, in fact, it's right. And one journey through the trauma of being in jail and incarcerated, you know, people are much worse off than they were before that stay. So.
Certainly. Now, we're talking about diversion programs. Can you help us understand the sequential intercept model, or SIM?
Sure. And I think that there's a fellow named Hank Stedman who has retired, but he was sort of one of the visionaries of the sequential intercept model. And what it really is, it's a methodology for mapping anywhere in the community where an individual with a serious mental illness could come into contact with the criminal justice system. So, for example, intercept 0, so it's sequential intercepts, hence the name. So intercept 0 is, you know, a crisis line in the community. So somebody with serious mental illness is having a crisis. They have a crisis line to call rather than 911. You know, intercept 1 is, okay, so maybe the police are called, but when the police are called, they have a place to take that individual rather than arrest them. There was a study of police discretion that was done in the 90s, and the number one determining factor in a police officer's mind when they're deciding whether to book someone into jail or to take them to an emergency room is whether or not that person's going to get a hospital bed when they get to the emergency room. Wow. And if they don't think that person's going to get a hospital bed, then they're more likely to book them into jail. And so then there's intercept 2, which happens, you know, in the initial phase of court hearings, intercept 3, once somebody's, you know, in the hearing process, and then intercepts once someone's been incarcerated and is coming back out. So it's all designed to try to favor treatment over continued cycling through the criminal justice system.
Yeah, and there are also various programs around the country. You mentioned the interaction with law enforcement. I was involved in some of the training here in Florida called CIT, which is Crisis Intervention Training, and helping law enforcement to understand the needs of someone with mental illness and how to interact with them and not interact the same way that they would with a criminal, for instance.
And that's an extremely important point in the sequential intercept, is having that police officer understand what they're seeing, understand that this person isn't able to comport their behavior to societal norms because they're oftentimes delusional, and to get that person into treatment. Although I have heard, and that's the gold standard, that program was developed in Memphis, and there's tons of studies showing that it decreases all kinds of bad outcomes to train officers in mental health. But I have heard police officers say, okay, I've been trained and I can understand when I see someone with a serious mental illness, but the problem is I have nowhere to take that person when I get called.
Exactly. Right. And so they maybe, like you're saying, almost take the path of least resistance or
somewhere where they think that at least this person is going to be seen to. At least there's a chance that they're going to be housed and cared for in some way rather than on the open street and experiencing severe symptoms, which when we look at our population, we're sort of the on-ramp with the IST commitments in forensic state hospitals. And we look through all the arrest reports, and it's always a very similar story of someone who is very symptomatic, totally not participating in consensual reality, making people uncomfortable with their behavior because they're out in public because they don't have a home. And, when the police are called, the individual oftentimes doesn't understand that they're interacting with the police officer, and some episode ensues wherein that person ends up getting arrested. And that's the typical story for about half of the patients that we have coming in right now. 2/3 of the folks we have coming in right now are homeless at the time they're arrested. And as I mentioned, 2/3. And as I mentioned, half of them haven't received any mental health treatment in the 6 months prior to their arrest.
This is remarkable. Again, I use the analogy. We as a society would just never tolerate this with any other medical illness. It's just shocking.
And nobody likes this. It's expensive. States are having to build more expensive state hospital beds, or they're having, the only real place that it's extremely difficult to manage someone with a serious mental illness is in a correctional setting, because that's a setting where rule following and control and custody are the most important factors. And if you have someone who's too delusional to understand that, no matter how well trained and superb mental health services are, jails and prisons are absolutely the worst place for people with serious mental illness. So the jails and prisons don't like it. The individuals who are watching these people suffer on the street or having their business disrupted don't like it. We in the mental health community who feel helpless don't like it. And most important, the loved ones of individuals suffering from schizophrenia have to watch their loved one fall into this cycle, and they're helpless. And it's just heart-wrenching.
It really is.
There's no one benefiting from this. Everyone's losing, but we're not doing something about it as a society.
Well, that may be beyond the scope of this discussion, but help me understand the psychology of this. What is the psychology of not doing something, of neglecting these people, especially versus other medical illnesses? What is it about mental illness?
It's a great question. And
well, actually, let me chime in here if I could.
Please.
It's not just mental illness, it's serious mental illness.
Yeah.
I think there's a misunderstanding, even among many mental health providers, that all mental illness is not the same, and that people with a brain disease that's very severe, has been around for hundreds of years, is 1% of the population, looks like it always has been, always will be, and these people lose their ability to make good decisions about themselves and sometimes I say it's a disease of insight, and it requires insight in order to know that you don't have any insight. So no wonder it's a problem. And I think many people just believe it's an extremely bad hair day as opposed to a somewhat bad hair day, or it's related to, insomnia or mild depression or mild anxiety, which are, I suppose, mental illnesses, but they have nothing to do with severe psychotic illness. It's a lifelong illness that prevents, people from being able to develop in the direction they were going until they got their first break.
Yeah, so it's maybe a misunderstanding of severe mental illness vis-a-vis other mental illnesses.
Yep.
And I think with funding sources and mental health systems, because a lot of the systems that are currently in place were developed before we had a rich understanding of diagnosis and syndromes, there is not that distinction in mental health systems, mental health funding, and oftentimes people with the psychotic brain disorders that wind up not benefiting from even states that have robust funding streams.
Right.
Because they're not affirmatively walking through the door of a clinic saying, I need help, whereas some other types of mental health diagnoses, people will.
Yeah, that's certainly true. And that leads me to another question, which is, this is a disease of insight. These people don't think that they need help. So great, we put them in the hospital, we treat them, and then they go out and they stop their medicine. So how do we encourage or legislate them to get treatment? How do we mandate that happens?
Well, that's a very interesting question. It's a political question. It's an emotional question, and it relates to involuntary treatments, which we have had many discussions with, or many discussion as a society over time. And Dr. Stahl and I did a paper a couple of years ago called Balancing the Pendulum, because we tend to swing from extremes, for example, in the middle of the last century where society locked up everybody, to extremes where it's virtually impossible to give involuntary treatment, to now another extreme, here we are today, where people are once again getting treatment, but in correctional systems. And can't we find that middle ground where involuntary treatment is used judiciously, scientifically, fairly, to keep people from reaching that far extreme? But it's, as I mentioned, it's a politically very difficult topic. And there's a whole segment of our society that has not yet forgotten the institutional atrocities of the middle of the last century. And they equate any type of involuntary treatment with that, understandably. Our governor here in California proposed, in my opinion, a magnificent proposal called Care Courts, which in my opinion attempts to balance that pendulum and really target, and it's not involuntary treatment, but target kind of assisted supportive treatment to individuals when they lose their insight, when they lose their medical decision-making capacity. And so that's being discussed now in the legislature. It's a very small number of people who would need these types of interventions, where not just the individual has a care plan, but the provider who gets funding for that individual is also compelled to deliver the care plan that's sort of overseen by a judge. So that's the Care Court proposal.
Care Court. And can you speak a little more about assisted outpatient treatment versus involuntary? What's the difference?
Assisted outpatient treatment, probably the most well-known program is in New York, and that's Kendra's Law. And it's a program where an individual is not, no one is getting, involuntary shots or anything like that, but an individual is presented with an alternative, sometimes, for example, to hospitalization, where they have a treatment plan and they're provided with case management, housing, medication. And if they follow their treatment plan, they tend to, after a couple of years, gain enough insight to start following it without the judicial component, which is the AOT treatment plan.
Right. So what if the patient does not participate or doesn't agree to do this?
I think oftentimes that they'll be hospitalized.
I see.
It depends. I think it's individualized, and it depends on the state. We have assisted outpatient treatment in California, but it's all strictly voluntary.
I see. So it's a form of shared decision-making, it sounds like. You involve the patient a little bit in this.
Yes, absolutely. Care Court's remarkable in the amount of consideration it gives to the individual's choices.
Mm-hmm. So this is a form of diversion, if you will. It sounds like you're putting these people now into the treatment system as opposed to the criminal system.
Before they get in the criminal system, that's the idea.
Yeah, even before.
So obviously, if you have to wait till they get so sick that they commit a felony and then they can be forcibly put into treatment, that kind of, ruins people's lives to be put in the criminal justice system. So we're trying to avoid that, but you're taking away essentially some of your rights potentially, at least that's how some people see it. We kind of think it looks a little bit more like, you don't see a lot of Alzheimer patients in tents on the street. There are laws that show when people are incompetent to make their decisions, there's a kind and very supportive way of trying to be able to help them in the dementing process. And it's very kind of, modeled on that. When you can't make decisions about yourself because you've lost your insights of medical care decisions, then those can be made for you. And, that it's controversial. Kate and I like to say, do you want to die with your rights on and you want to in a tent and get kicked to the curb, and that's a good way to live, homeless and exploited and unmedicated, because you don't really realize it. And funny thing, I was just visiting some of diversion housing in Southern California, and did that a few weeks ago. Was quite impressed with the kind of environment and milieu and feeling you had going into that. And they said that people stay about 2 years, and these are people that are diverted from criminal justice, so they have committed a crime. They may not ever go to trial for it or, be judged for it, because if they're successful in this program, they can skip that. But they were saying how it takes months, if not almost the whole time, for people to realize that they have an illness, and that even longer once they get it that they have an illness, that the medicines help them. And so that kind of insight is one of the major tasks of this housing, one of the projects they work on. And they do it a little bit by, other people who've been there longer, who have gotten to that point, counsel those who come there and haven't been there very long about their, if you will, insight into that. But it does not occur quickly. And these are medicated people who take a long time to figure out they have an illness and that their medicines work. So that is quite interesting, because how can you expect someone unmedicated with the florid symptomatology to ever get to that point?
Yeah. Well, we know, Steve, that when people do stay on their medicine, there is continued improvement. It's just not all in the first 6 weeks. There's continued improvement over time.
Not only that, but, it's shown that in the more times you have psychotic episodes, the more resistant you become to the medication, and that our best shot at helping people is early onset psychosis, or even first episode, where you try to prevent recurrent psychotic episodes, recurrent hospitalizations, and all the brain damage, let alone the social and the economic damages that occurs.
It seems like, once again, other countries have it right. They use a lot more LAIs, and it's an argument for why don't we use more LAIs earlier in the illness?
Well, I don't know. I think that's very interesting. It's a little bit of that starving in the midst of plenty we were talking about. We have these technologies, we have medications, but patients that really need them, that are this sick and are homeless and in the criminal justice system, they're not getting them.
I can't help but think about how we would treat tuberculosis way back when, I guess. When somebody didn't take their tuberculosis regimen, they were put in jail and given the medicine. Perhaps that's a little strong and a little cruel, but it seems to me like, here again, TB was treated differently than mental illness. We wouldn't allow this to go on.
Yeah, it's too bad. I mean, you're talking about, millions of people in the United States. If it's 1% of the population, you're talking about, 3 to 6 million people, depending on how well you decide. So it's a lot of people who are suffering, and it will always be this way. If you don't resource the system sufficient to take care of that many people,
Exactly.
It will collapse.
Well, the argument you always hear, Kate, is, mental health is competing with schools and bridges for funding. And I don't know. What do you think about that?
I believe that if we had a coherent system to take care of individuals who develop psychotic brain disorders early, proactively, supportively, we would save money. It's $1 billion a year to put people through, as I mentioned, the IST process, which is a pointless use of resources and funds.
Sounds like a revolving door.
It's a result. 70% of the individuals that we restore to competency recidivate within 3 years. It has no public service function, and it's certainly not good for the patients. So, and, in California, that's 10,000 people a year cycling through. For the same money, get those people into a house with a case manager, some medications, and some support, and they can have a meaningful life.
Well, in the support, there's various treatment and support modalities that are evidence-based. And yet again, it takes funding to put those in place and an administrative structure, I suppose. And that's part of what you're saying, Steve, starving in the land of plenty. We know that these people, their treatment is often funded by public funding. It's Medicaid, Medicare. They don't always pay for these other therapies and other programs that we have that we know are evidence-based.
Yeah, it's too bad. I mean, I think that we are on the threshold of an era where if we realize it's cheaper to house these people than to put them into prison, and it also will take a notable percentage of the homeless currently off the streets. Where have you ever heard that doing the right thing is actually less expensive?
Yeah. No, it's true. It just seems like common sense, and there is data on this, as you're saying. It's just amazing that it's not happening.
And we know what to do. I mean, we know what a good mental health continuum of care looks like, and we know what to do with an individual who's developing schizophrenia to keep that person well and stable in the community. It's not that we don't know what to do. We know what to do. It's just that the ability to implement that takes social will.
That's right.
Political will. And that's what we've come to. You know, I was going through a period of time where I wanted to form a political action committee of psychiatrists to lobby for a system to care for people specifically with psychotic brain disorders, because it is pretty straightforward. I mean, all you need to do is get a copy of Stahl's Essential Psychopharmacology and some case managers and some housing, and you're set.
Yeah. Well, there again, the irony, as Steve said, is we don't offer our best treatments to people early in the illness. We're forced to use generic medications, and we don't use LAIs, and so we're really not implementing state. We would never do this with cancer. Can you imagine bringing your mom to an oncologist and him saying, well, I have this old chemotherapy that doesn't work as well and it's going to make her really sick, but we're going to use that. You know, we wouldn't tolerate it. It's just crazy.
Well, what is interesting, I'll just spill the beans here. Kate and I were just, in fact, this morning on the call with a Vatican priest who is a neuroethicist and a PhD in neuroscience. And we're working with the Vatican to develop our three-legged stool for these patients. And so one of the legs, which I thought was the only leg you needed, was psychopharmacology. But although the drugs work to a certain extent, they're not accessible to a great extent, and certainly not on a continuous basis, you know. So the second one is housing. And we're finding that places like California are spending an immense amount of money on housing because it's cheaper than building another state hospital or keeping people in jail or prison. But there's a third leg, and that is what was exemplified, I think, by the Vatican in general, but so by the South Central LA housing. It's called meaning. And how are we going to be able to take care of people if we can't all see the humanity in someone, with this horrible illness? And behind that, they may have done dumb things, they may have done illegal things, they may have done terrible things in some cases. But what is their humanity? And being able to see their humanity while housing them and giving them medications is the way forward, we think. And it seems like we're at the precipice of the possibility of actually being able to do that, even in places like California, where you've got now housing and you've got, like this CARES court coming through legally. You got people like Kate working on policy. We might just knock this thing. We might just figure it out.
That would be amazing. And it would be amazing if other states would adopt these things and would share best practices.
Keeping up with the latest in psychiatry shouldn't be a struggle. SynovianFieldMedical.com is a new website for clinicians where you can find a library of free, hand-selected resources, such as videos and infographics on important psychiatry topics. You can request an educational program for your practice or connect with Synovian medical professionals in your area. Synovian wants to help you get all of your psychiatry questions answered. Go to SynovianFieldMedical.com and explore what Synovian has to offer.
I want to shift gears just a little bit here and talk a little bit about violence. And Steve, you've alluded to this when you say sometimes these people do horrible things. Kate, what are the main types of violence and how do we distinguish between them? And then Steve, I'm going to ask you a little bit about brain circuitry here.
The way that we conceive it here, and this is based on research by our research partners at UC Davis, as well as some New York researchers, is that at least in the psychiatric setting, we have psychotic violence, which is oftentimes a response to persecutory delusions, where someone believes that they are protecting themselves when they're committing an act of violence because of a delusion. There's predatory violence, which is committed more by people with a sociopathic, psychopathic personality style that's goal-directed, instrumental, planned, organized aggression to gain something for a purpose. And interestingly, the most common type of aggression that we see, and this has been shown in other studies, is impulsive aggression, which is multifactorial and can really cut across all different types of diagnoses.
Wow. So those are the three types. So Steve, what about the brain circuits associated with each of these types?
Well, clearly the brain circuit of psychosis is the same one, whether you're violent with your psychosis or not. That kind of psychosis doesn't make any sense because the person often thinks they're under attack when they're not, and there's somebody that's innocently sitting someplace and they go up and hit them because they think they're going to hurt them. And that's treated by, treating the psychosis. There's a lot of impulsivity involved in people that, they have some cognitive limitations, of course, in this illness, and they just react to input that causes them to, without thinking, do something that could be harmful.
So is that a failure? Is that a failure of top-down regulation, or is it a overactive down-up?
Well said. Both. I mean, I think you're right. We found that the most violent people, either peer on peer, patient on patient, or patient on staff in the whole system, 4% of the people commit something like 40% of the violence. And they're frequent offenders. And in addition to having a psychotic illness, what else do they have? A cognitive deficiency, possibly profound. So those two things create a lot of impulsive violence.
And how do we treat those? Of course, we treat the underlying psychosis. Does that help with the impulsivity?
Yes.
Or do we specifically go after impulsivity?
Sometimes we find that the doses of meds that we need to treat impulsivity are higher, and sometimes we find that clozapine is necessary. But we do have tools for that. The last part, of course, the psychopathic one, which is lying in wait and planning and being manipulative, there's no treatment for really, and certainly no medication.
Yeah, sadly. So those are the people who should be locked up, if you will. Those are the people who should be incarcerating. Okay, I think we talked a little bit about how to treat these different types of violence, particularly psychotic and impulsive. So in addition to medication, what kind of psychotherapeutic interventions do we need to be thinking?
Well, you want to talk about DBT a little bit, Kate?
We've implemented dialectical behavior therapy in our system, which is complicated to implement a very manualized treatment in an institutional setting. DBT is, seen more in the outpatient setting. And we've had spectacular results with DBT.
For which types of patients?
A variety, but the classic DBT candidate is an individual with a borderline personality disorder who has difficulty with regulating mood and affect. To Dr. Stahl's earlier point, this was actually a really fascinating project that we did. And I do believe it was your idea, Dr. Stahl. But we found the individuals who were repetitively violent in our system. We had no idea what we were going to find. We sent out a team of really great clinicians to look at a subset of this population and found the vast majority had a cognitive issue. And so in response to that, we've implemented a pretty extensive cog rehab program here. Our team here has relied upon Dr. Stahl and other experts in the field of cognitive rehabilitation. And so that's another sort of way to address the impulsive aggression. We do CBT for psychosis, for individuals experience psychotic disorders. One thing that has changed the game for us is becoming trauma-informed. So many of our patients are behaving in a way that is driven by the trauma they've experienced,
Of course.
behaviors that make sense if you understand how their life has gone. So we've been, over the last 5 or 6 years, working very hard to become a trauma-informed system.
I must put a plug in here for psychopharmacology, because one of the things we found is, although we cannot necessarily help people very much with cognitive problems, we can sure make them worse. And one of the things we do is reduce anticholinergic burden because that's very bad. And it's a big thing we do all the time, giving people gratuitous amounts of cogentin and so forth, and also being unaware that many antipsychotics have powerful anticholinergic effects. You give a couple of those and you give some cogentin, and all of a sudden, all of us would have cognitive problems. So stopping anticholinergics often is as powerful a thing as you can do to help cognition.
Absolutely. And I would think benzodiazepines can be an offender here as well, and also make people more impulsive. So, yeah, Steve, I've sometimes joked I've done more good in my life taking people off meds than I have putting them on meds. So I think that's very wise. Just good principles of psychopharmacology.
Yeah, there's a lot of polypharmacy by people who aren't figuring stuff out and are well-meaning, and they just add something and add something. You see it a lot in outpatients as well. It's a common problem. And there's this interesting, there's even a word for this now. Andy, you and I have been doing it for years, and we didn't know what it was called. But you know what it's called? It's called deprescribing. Deprescribing.
Yeah, I like it. Well, it's really like you said, we add meds all the time, but it's rare to see people taking people off meds. So it works both ways. Let me go back, Kate. So you've given us a couple of these interventions. Do you use DBT at all for people who don't necessarily have borderline personality disorder? Because that's the classic.
Yes. And we're actually, because we've seen such good results with our DBT formal DBT programs that have fidelity to the, classic DBT, we're really starting to generalize just DBT skills training. Everybody can benefit from being able to, regulate their emotions and use coping skills and so on and so forth. So absolutely, everything that we do in our system is we sort of pilot it, collect some data, see if it works, and then try to generalize it if it's something that's effective, because our patients are so complicated. I have a talk that I do that has a puzzle piece, and it starts out with, psychotic illness, and you add in substance use disorders, trauma, criminalization, impulsivity. And, there's just so much. And it ties back to our conversation about criminalization. A lot of this is stuff that happens to people who start out with a schizophrenia spectrum disorder, and then they pick up criminogenic risk, and they pick up trauma, and they pick up a substance use disorder because they've gone neglected. And so by the time someone comes to us, there is so much to treat, so many dimensions of the clinical picture to treat. We were talking earlier about sort of the three etiologies of aggression. The least common type of violence we see in our system is psychotic violence, because of course we're so good at treating it because we have, Dr. Stahl and his team. So, when I started my work, I had a grossly oversimplified understanding of what it is we're supposed to be doing in a state hospital when we have the good fortune to be able to really sit down and treat someone instead of just restoring them to competency. And you have to treat all these dimensions that are the sort of end result of ceaseless criminalization of people with psychotic brain disorders.
Boy, that's really well said. I think you're absolutely onto something here. And people, it is almost like the elephant, isn't it? The blind man sees the elephant either of the trunk or the tail or the body, and you're seeing something different no matter how you look at it. And we really do need to throw a lot of different treatment modalities and a lot of resources at this. But again, it is not only the ethical and the right thing to do, as Steve said, but it is cost effective, obviously. Putting people in the criminal system is the most expensive way to treat them, if you call that treatment. I think we're all aware of the statistic that the largest mental health facility in America is the Los Angeles County Jail, and that's just shocking. But we're not just talking about jail. Of course, we're talking prison system as well. There is another program that you guys have in California, the California State Hospital Violence Assessment and Treatment Guidelines, CalVet. Can you tell us a little bit about that?
This started when we first started out, 2011, 2012, and we were seeing more aggressive behavior. And we weren't just seeing it here in the state hospitals. We would talk to community partners in other states. And I think it's sort of this result of criminalization and all the dimensions I just discussed. And we thought that we just had missed a class in residency or, And so we went to the exalted Stephen Stahl and said, could you talk to all your famous friends in the world of academic psychiatry and tell us what we're missing here? Because this was before we really got that multidimensional understanding of the population. And thought we had, missed something. And so he went out and came back and he said, there are no guidelines. You guys, he said, you have to write them yourselves because you have been doing this. You have been successfully treating these folks. And he organized us into multiple teams, and we really got an outstanding understanding of the, current literature and best practices, and wrote the CalVAT guidelines ourselves. So it's the California Violence Assessment and Treatment Guideline, or CalVAT, and really based it on those three types of aggression, right? What do you do for someone with psychotic aggression? And that's very heavily on the psychopharmacological algorithms. What do you do with someone with impulsive aggression? And we approached each type of aggression from a psychopharmacological perspective and then a psychotherapeutic perspective.
Well, this sounds like a model that other states could be using. So I'm sure you're going to be presenting, publishing, all of that.
They're out there, and we do share them quite a bit.
We've talked a little bit about the types of people or the types of mental illnesses that we're talking about here that end up getting criminalized. But I think what we're giving the impression of that it's just schizophrenia, and certainly psychotic illnesses in general, but I can't help but think of the case of Andrea Yates, the woman who was bipolar, actually, and killed her 5 children, if you remember that story. And she had 5 successive psychotic postpartum depressions, exactly, which is a big clue to bipolarity, obviously. But apparently in between episodes, she functioned as a nurse and, was relatively high functioning. So are we also talking about bipolar illness? Are we talking about other illnesses as well here?
We're really talking about psychotic disorders. And, and so you have to be specific enough to make sure that people understand that you're talking about individuals who are experiencing delusions, hallucinations, disorganization, and cognitive issues. And that can be individuals with mood disorders. I think in our discussion, we try to be mindful that there are a lot of people walking around this planet with a mood disorder, and not all of them are, very few of them are experiencing the same type of course as people, for individuals with the schizophrenia spectrum disorder who are not going to return to the baseline, after a mood episode's resolved and so on and so forth. They just are having a much different course.
Oh, certainly true. But the Andrea Yates case, of course, brings to mind a situation where when psychotic, there certainly was interface with the criminal justice system. And you mentioned borderline personality disorder, and of course, they are prone to psychotic events as well.
Although it's interesting enough, many of those are more prone to self-harm than they are to harm of others. Not as a rule, but certainly it's seen frequently.
So the movie Fatal Attraction was a bit of an exaggeration, you're saying?
Well, I'm not sure.
Maybe not. Well, this is extremely helpful, and I'm just wondering now, so we're talking about these various tools and treatments that we have available clearly. And the question is, how can we, as a society, as healthcare providers, as citizens, how can we influence the system? What can we do about this?
Well, and this is why we are doing podcasts and writing about this and talking to, spiritual leaders, because we have to change, as our colleague from the Vatican says, we have to change people's minds, and we, most important, have to change people's hearts. And we have to get a social will in our communities to do something different for these individuals. And so part of that is education, helping people to understand that the person that you see lying on the street has a brain disorder that, happened to them. It wasn't a choice that they made. When you listen to the families of individuals who developed a serious case of a schizophrenia spectrum disorder, these are wonderful, perfect children, the light of their families' lives. And then when they turn 16, 17, they start acting funny. The parents think they have developed a drug problem. They get into a power struggle. And then the dawning realization that, no, my kid has a brain disease. And then the kid stops trusting the parents and gets in trouble with law enforcement and start sleeping out on the street. I mean, it's the same story over and over again. And it cuts across all socioeconomic strata. It cuts across everyone, and it's 1% of our population. So everybody knows someone whose mother, sister's brother developed schizophrenia. And we need to start to care that the trajectory is so tragic. And that just comes from community work, raising awareness, educating people, and trying to change people's hearts and minds. I just have a vignette. I was talking to a colleague who was, not even in mental health. This was an IT consultant or some such thing. And I started talking about this problem of what happens to people who develop schizophrenia. And she said, well, that sounds just like my friend's child. And I said, well, how at the end of my discussion with her, how is your friend's child? Well, he's dead. Oh. And that's what you hear. They're either, incarcerated or, the significant increased mortality rates in people with schizophrenia. We just have to change hearts and minds however we can.
No, I think that's well said. And, it gets back to the question I asked you earlier about how do we allow this to happen? How is it that we treat mental illness so differently from other forms of illness? And I think that another part of this, another aspect is it's a form of denial. We're so scared that it could happen to us. And, if given the choice, would you rather lose an arm or would you rather lose your mind? I think it's very clear what people would choose. I think we're scared of this.
Well, that's true. I think we don't understand what we're fearful of. And I think it's Kate hit the nail on the head by saying more education that this is a brain disease and it's something you didn't cause. And it's part of being a human being to have 1% of us with this. And so these are our brothers and sisters, our brethren, if you will. And but for the grace of God, go you and I, as the saying goes. And the idea is that to do what we can with the resources that are available in our society to lessen the load on them.
Well said. And I have to really applaud both of you for the work you're doing in California and the work you're doing in getting the word out. And that's why I think this podcast hopefully will help with that process and will open up some hearts and minds. And, I certainly hope we're all in this field because we do care about these folks and we do feel like maybe we can make a small difference. So thank you very much for doing that. And thank you very much for talking with us today. We're out of time, unfortunately. I definitely feel like there's a lot more angles to this we could talk about. Kate, is there a place people could go to learn more about this?
There's pockets of information all over the place. So, there's the Gaines Center from SAMHSA. The Treatment Advocacy Center has a lot of good information. We've done some publishing. Dr. Stahl and I have a body of papers that we collected into a book. So I think it depends on what angle you're looking for, whether it's a policy angle or a treatment angle, but there are resources out there. And once you start digging in, then you start to find the other resources.
Now, your book specifically, is that available? Is it published?
Yes. I'm self-conscious about plugging our own book, but yes, we have a book called Decriminalizing Mental Illness.
Well, that's convenient. That's the title of this podcast, so that's okay. I think it's all right to mention that.
And for those who have access through the library, all of those chapters are published as articles in the journal called CNS Spectrums, so you don't necessarily have to buy the book if you have access to CNS Spectrums to see those articles.
Great.
And
thanks.
That's more of our academic approach, but we are working on a book now more for the layperson, to kind of lay out some of the more social aspects of this.
Well, as you said, that's a critical piece of this. We need people to get up in arms and get behind this and push their politicians, for instance. Well, again, I really want to thank both of you. This has been a tremendous conversation. Kate, thanks so much for your time. And Steve, as always, for your insights. And I want to thank you, the audience, for listening. Please stay tuned. We have many other podcasts in this series of the PsychopharmaStahlogy show. Probably by now, like me, you're pretty amazed at all the different things that Dr. Stahl's involved with, all the different ways that he influences our field. So thanks for doing that, Steve. And for more information about NEI and what we're about and what educational products and services we offer, please go to our website, NEIglobal.com. That's NEIglobal.com. Thanks for listening.
Thank Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.